So, welcome back, everybody. I hope you got a good coffee and you're ready to go for the second chapter, which is more into clinical cases, one by one with different individualities. So let's go. So, this is as Amina, the happy patient after 1 year. Now, we were talking about re-establishing the structures around the implants or maintaining them if they are there in certain proportions, if you remember before the break. But the re-establishing of the structure is not a single condition. We have to maintain this. And which is the most common complication around implants nowadays is peri-implantitis, of course, along with a ceramic chipping, along with screw loosening and so on. But peri-implantitis is something that is irreversible at some point. So that is why an every 4 months control and professional cleaning will be necessary. Why 4 months? Because we have, after 3 months, we can have a mucositis. Can you treat a mucositis reversibly? Yes. But can you treat a peri-implantitis predictably? No, because it's the bone involved. So that is why by a 4 months professional cleaning, we check the patient, we see if we have a mucositis and we treat it, and we don't give the opportunity for bone loss or for any other additional complications. That is why we also use once a year an photodynamic therapy for decontamination, or you can use any other decontamination techniques out there, ozone or whatever you have and what the literature is showing you and is giving you. And once a year we do that occlusion control sensor-based. Now, why this sensor-based control is important is first, we did in a digital way this nice reconstruction, but it doesn't have any, any advantage if this result is not maintained over years. And we had before metal ceramic reconstructions. We cemented with provisional cement. So all this things gave a certain resilience of the constructions over implants. Nevertheless, today we work with titanium abutments or zirconia abutments, zirconia restorations, IMAX ceramic, which all have a different or a higher impact and a less elasticity or resilience as before. That is why those constructions are prone to bone loss, because bone loss is the response to overload or to shear load on the implants if the occlusion is not in harmony. And we learn from the initial occlusal concepts on implants that we have to have the implants in a implant tooth supported reconstruction. We have to have less contact on the implants. But how much less? And the 200 microns occlusion paper gives you very, very approximate and not concrete and not precise information, since sometimes you don't have blue points on the implants or on the crowns. When you have no points, it can be the situation that you have too much contact, not less contact. That's why this implant time delay can be measured by this device, which is has to be less than 0.1 second. The sensor-based device is giving you a very fine adjusted by the second and by the microns, by the 25 microns precision occlusion. So it gives you very, very precise data about occlusion, which is mandatory and necessary in an implant restored, teeth or denture. So either you have a time delay when you have teeth and implants in the same construction, or when you have only implant reconstruction, like in Azamina's case in the upper jaw, you call it disclusion time reduction, which means that in the movement, in the lateral movement, and also in the multi-bite, you have less than 0.4 seconds disclusion time. That means that the teeth are not very long occluded, very long overloaded. And all these values you can read in one of the chapters of this handbook of research on clinical applications of computerized occlusal analysis in dental medicine, wrote by Robert Kirsten, and there is a chapter on digital occlusion on implant rehabilitations. You can have that also with discounted if you're a member of DDS, for example. So we need to avoid the prosthetical failures like the screw loosening and the ceramic chipping, which can be occurred or caused by overload or shear forces. And of course, the peri-implantitis, which is bone loss plus infection. So we prevent the infection by every 4 months professional cleaning and once a year decontamination. And we avoid the bone loss or prevent the bone loss by avoiding overload over the implants by a very precise adjustment of the occlusion. So this is also a subject of a multi-center study, and the results will be published. The preliminary results were shown in the consensus conference of the DDS, but it will be published soon at the end of the study. So by this device, we do an initial multi-bite, which is adjusted and contoured. You can see that the right and the left side should be equal, right? And the maximum force is by 100%, like the black line is showing. So, and we do that every year. So all this situation, and of course we do after 1 year in this prospective study of the aesthetic parameters, we do an intraoral scan and a combing CT, and that is why the digital data acquirement is important and useful also for follow-up of the cases. We can see volume loss by doing again an intraoral scan, as I showed you before the break. And we also can see recessions, which can be compared. So an intraoral scan is way better than an intraoral camera, because you can match the results of the or the images of the intraoral scan and see the differences in the volume, in the recessions, and so on. So after 1 year, we do also an occlusal adjustment, and in order to see if the muscles are also relaxed, and this is something that you can really adopt in every full arch reconstruction in order to give this patient a long-term guarantee, is the electromyograph. You can see the red and the green contraction of the muscles. When you have teeth and implants, teeth are moving, and premature contacts and interferences will occur even if you, after the insertion or after the insertion of the restoration, you had already adjusted. So there, especially in teeth and implant reconstructions, you have changes. So that is why you need to do that yearly. And also, the electromyograph shows that at some point masseters and temporals are connecting. So we adjust again, we eliminate the red points. We don't go into details. It's just an information for you to maintain a very high demanding restoration, high leveling restoration on the long run, right? So the restoration will be adjusted in multi-bite, so everything has to be blue, as you can see here. And you can see that when it is adjusted, then the muscle activity, like red and green, the muscle activity will decrease, and it will be less. So this is what we need to have. Okay, so let's go further on. You see very, very little muscle activity also in the laterality movements, which is also very important to see. Right lateral, okay, protrusion. So all the movements has to be done. Okay, so by matching, again, a new intraoral scan, which can be repeatedly done with any other damage on the patient, with a cone beam CT, which is allowance we have from the patient, for the study purposes, is having the conclusion that no changes on the bone thickness and on the soft tissue, so on the volume have been done. So the situation of the aesthetic and volume parts, but respecting all these parameters, is stable. So, as I said, this is a case which we learned a lot, and we applied all these rules in many other cases. Nevertheless, as I mentioned before the break, the situation is really different from case to case. So, for example, and we have disastrous situation like this one, and you will see a couple of them. And the question which is coming also up is, do this patient clean after we did the restoration? And yeah, astonishingly, the patients, all these patients are anxious patients. That is why they are treated in full anesthesia. And after this, all this burden, which they overcame here, their fear, and they did a lot of you know, a big step in order to get their beautiful smile. And when they like it, then they really put energy in maintaining that, that result. But also by motivating them, giving them the long-term guarantee only under the condition that every 4 months is a professional cleaning, a decontamination once a year, and occlusal control once a year, because that is a synergetic win-win. And we have the opportunity every time when this patient comes to control to re-motivate the patient for every 4 months, like with the kids, to reinforce the cleaning, to reteach and re-motivate for the cleaning. But astonishingly, in them, we have several, I mean, long-term and several cases and statistics about that. Patients are really very consequent and they don't mess up it again. So this patient comes also with a disastrous situation. So we do the digital data acquirement. As I showed you before the break, that means an cone beam CT, an STL file, and this STL file will be implemented into the CAD/CAM software first. to do a smile design, a virtual smile design. Then it will be transported from the CAD/CAM software to the exoplan, to the planning software, which is coupled also. And then we will match all the data, the virtual walks-up, the initial walks-up, the movement of the jaws, and the cone beam CT. And that is the situation where, or this is the situation where we plan the implants, the guide, and the provisional. So again, as an reminding all the workflow, right? So we plan here also, there are again young patients, and they want, especially in immediate loading or immediate placement, immediate loading procedure, we place the implants in the extraction socket, and it's no reason to do big bridges or all on 4 or all on 6. We always take into consideration the structures which we have, and we can maintain and use it for a best replacement for a tooth, which is an implant if the tooth is not capable to be maintained. So that is why the treatment planning is important. And I always got the question, maybe you will have it at the end, why so many implants? Because it's a young patient, because we see an implant to be the best replacement for a tooth. We don't force things. So if there is no immediate placement and it's an edentulous jaw, we don't go for tooth by tooth reconstruction, is also not possible. But if it's an immediate placement situation, we have all the tools to give this patient a very nice, natural, similar result without jumping teeth over, without doing bridges which are compromising the hygiene, which are bringing bone loss with it in an edentulous parts, and so on. So there are more religions to this theory, and nevertheless, the high success rate and the high aesthetic success rate is confirming this theory, right? So you did a face scan which matched with the cone beam CT, and you implement, this is the beautiful thing on an established workflow, that you can take the cone beam CT and the intraoral scan and the face scan and the cone beam CT and place it in the same software of planning of the CAD/CAM parts of the treatment and planning of the implant parts of the treatment. And when we go to the implant planning of the treatment, then again, we take into consideration studies which are confirming us that keeping the teeth will, keeping 2-3 teeth for the stabilization of the guide will be very useful and giving us a much more accurate result than the soft tissue support, and there are several studies behind this. So we do that, and afterwards we extract the teeth which are remaining. Sometimes this situation can be done like that. Sometimes, as you will see later on, we need to use 2 guides to place the implants, and you will see how it works. Here we extract the teeth, and we have a true implant-supported restoration in a beautiful way. And this is also done by Uli Hauschild, very nice, nicely planned. I confirm, actually, Federico Mames is the young person, the IT person behind the technician. So we have today hybrid technicians, which are digital and aesthetician at the same time, and this would be the ideal situation. Now, based on this matching, we draw the guide, and the drawing of the guide is a skill of the technician also. This is where I cannot really give my input since I don't plan myself. Nevertheless, we can as doctors, and we have freaks, IT freaks also among the doctors too, so you can plan by small very easily to plan the guide yourself in the same software. So that is something that I did already, but big cases I still don't do. Now, the guide has to be, you can see that the guide is quite close. So that is always a question, how do we design it? Some of the theories are saying, okay, you need cooling. So you need to do that guide a little bit more open in order to facilitate the cooling of the implant. Nevertheless, experience-wise and statistic-wise, the guides which have a kind of grid or frame, and especially in freehand situation, are not stable enough and not rigid enough. That is why I prefer, and it is preferred to do a compact guide, which is assuring me the stability of the guide and of the sleeves. So that is because internal cooling is still, it's not existing. So that is, for me, from the two disadvantages, the one less. Now, after we planned all provisional guide and so on, we go for the making procedure. The making is, as I said, the printing of the guide supported by teeth. You have to be careful to have the sleeves very tightly polymerized into the guide. Experience is the name you give to your mistakes. That is why I'm telling you, in order to not to do my mistakes, do other ones, because the range is very big. But I would like to reduce as much as possible. So if it's not tightly polymerized, then in the drilling procedure, which is a skill of the surgeon, you can have the rings come out of the guide. This is one. Second, when you place the drill through the sleeves of the surgical guide, before you go to the surgery, you should test the drill through the sleeves, because sometimes a resin is staying into the sleeve and is hindering the smooth gliding of the drill through the sleeves. So there are all things that already happen, and I would like you to avoid this in order, or to prevent this in order to, and to remember this, what can happen. Remember again, when you have thin jaws, please open or make the first guide and probe, and mandatorily probe in any anatomical region where you have a nerve or a sinus which you would like to avoid in your surgery, right? So the provisional. What about the provisional and occlusal situation? So we have what is not coordinated is the occlusal positioning of the provisional, because we have screw retained provisionals, and the position of the occlusal plane, it's really difficult to be placed and to be saw in a full arch reconstruction and in a full narcosis, full surgery, in a full anesthesia. So that is why there are many methods to do the provisional. In that case, there is an occlusal palatal plate which you can use in order to step it, to place it in the right position, and the lower jaw will be done accordingly. And you will see 2-3 other methods in the future case. So this is one case, if it's possible, right? So this is the making, and the done procedure is the surgery. I won't show you every time the surgery, because it's really unspectacular, especially when you do it flapless. It is something that you do also internal sinus elevation or Versa technique. You can do through the guide without removing the guide, and the implants will be placed by mountings, which are fixating the implants in the position and fixating the guides additionally. So the more implants you drill, the better, the more stable it is. Then you remove the mountings, extract the teeth, and then you have the pure implant supported reconstruction. Okay, so this is the lower jaw, and this is the situation into the surgery, upper and lower. And after the removal of the guide, we see the perfect positioning of the implant, the way we planned it. 4 millimeter depth, we have depth from the marginal gingiva, from the margin of the gingiva, or from the margin of gingiva which you want to achieve, and also 4 millimeters from the collar of the implant to the most buccal contour. That means it's an added dimension of the bone and of the soft tissue. You see always multi-unit abutments which can be tilted, but the planning is, I always do the planning in a way that the multi-unit is straight, so I don't have to play around in the surgery. A short surgery is always a good surgery for the patient. We have to simplify the procedure, and also to go through the surgery mentally, through the whole surgery before, in order to have it like Michael Schumacher used to do or a car racing, because then you went through it and all the other small details can be solved without any problem, because the main road is done. So, of course, this gap will be grafted with a non-resorbable material. I don't go, this is not our topic today, how we graft, but otherwise the bundle bone will disappear. But there are always the static and the digital factors which has to be taken into consideration. Sockets which we don't use and will be overbridged, they will be grafted also with a non-resorbable material, and we always add a PRF, like growth factors, in order to have a nice soft tissue rehabilitation, as you saw also before the break. Very little sutures if it's possible, and this is the provisional of the patient. So this is how the patient went home. Again, the implants which are not having the primary stability or have an external sinus elevation are not to be loaded. But generally, the ones which are not having a primary stability, as I said, is not be loaded, but we have enough implants to be loaded. This case will be loaded by multi-unit abutment and screw retained restoration. I mentioned that the positioning of the occlusal plane or the incisor line has different methods. Now another method is, and this is another method which I can mention, is the stucked guide. This is a lady which has removable denture, as you can see there, very anesthetical as she came, and Uli and Federico did a stucked guide. He made a guide which is pinned by the jaw as a fixation, and all the other parts versus surgical guide, provisional, and all other guides which we need. Maybe a bone reduction guide, not at this time, but can be possible, will be stucked on this first guide. So that you can see on the palette like a resin point and with 3 dots. So there, and also in the margin, will be stuck all the other guides, so to maintain everything in the position which we want. So again, the guide is still supported by the 3 teeth which we maintain until the end of the surgery, and then we will be removed. You can see then multi-unit abutments, and you can see on the left side that the sleeve guided the sleeve guide will be stuck with those buttons in the palate and at the margin. So it has also additionally a controlled position. Nevertheless, the control of the guide, and this is what I'm saying, is you have always, and the guide, this is the skill of the technician to construct the guide virtually, to see the perfect, to give you the opportunity to see the matching and the perfect contact with the teeth remaining. So this is an additional control of the precision of the position of the guide instead of the pin supported guide, which you don't have any control about. So you understand now why we need to keep the 3 teeth as an additional precision, because the accuracy of our procedure generally, the difference of the accuracy between the planning and the delivery and the final result, which we always check. And we also not check, I mean, there are studies that are always checking all the workflows with all the technologies. Conclusion is that that lack of accuracy, which can be now not 4 millimeters, but around 1 millimeter can be, is depending. Again, I repeat, of the positioning of the patient in the cone beam CT, of the precision and accuracy of the intraoral scan, of the accuracy of the matching between the two, of the precision and accuracy of printing the guide, and of the accuracy of the surgery itself. So all these parts are important to be accurate, precise, and also the transition from one part to the other should be smooth and accurate. And this is what we are working on in order to reduce the difference of the precision between the planning and the delivery and the final result. Okay, let's move forward. So this is the stuffed guide. You see, we extracted the teeth and we left only the implants. And this is the provisional, which you stuck also over the first primary guide, which is pinned, yeah, and on the palate. So there's no way not to have a nice occlusal restoration. So that is, this patient is initial. Here she was with a provisional, and of course with a final. Yeah. Another young lady. This is also an older case. She had, she wants also the teeth in the upper jaw, they were mobile and not to be kept. She wanted fixed teeth in the same session. Now, what is important about that? Now, we would like to have implants also in the frontal area, but instead of extracting the tooth, placing the guide with a pin or some soft tissue supported, what did we do? We used two guides, as I mentioned before. So that means we make a scan, digital walks-up, matching the cone beam CT with a scan, and then go as the steps were before. I don't want to repeat it, but the more we repeat it, the more you realize that is, or you stays in the memory. So we do two guides. The one guide, which is on the left side, you have is supported by the teeth. The second guide is supported by the mounted implant. So you extract the frontal teeth, mount the second guide on the implants, and place the implants in the frontal area. Again, here also we do internal sinus elevation, which is very many times possible. If it's external, we have to remove, of course, the guide and do it externally. But so you see the positioning of the implants with the parameters mentioned before. The tissue is a little bit thinner than accordingly. So we use matrices to seal the socket, which is increasing the soft tissue quality. The provisional will be made in advance, and this time without a metal frame. The model will be also printed, and the provisional will be fit on that model. In this case, you see we have steps. This is a question, what is digital? You know, well, digital, you can go only really virtual with all the planning and just make everything ready, but you can also print the model and materialize and the provisional and match it on the model. This is still digital, right? So now this is the final reconstruction, which is also a very highly aesthetic tooth reconstruction. This time not necessary, but that is how we planned it in the beginning. It was also a study case. So the patient is really very happy about that. Okay. And checking the dimensions of the planning, I mean, setting the parameters of planning, again, repeatedly, around 4 millimeters buckling between the color of the implant and the most buccal contour, the yellow line there. And the depth of the insertion is also around 4 millimeters, from the most gingival contour to the color of the implant. is also around 4 millimeters. That is why in the planning it's important to have a right matching between the STL file and the cone beam CT. For that purposes, the accuracy of both is very important, and the positioning of the implant, so of the patient. So it's the same result afterwards, so it's a stable result on time. This is also subject of the study. So this is Suzanne. What has Suzanne? Suzanne has very, very compromised prosthetic situation, but not only prosthetic, but also tooth situation. It has a gummy smile a little bit. And at that time, we were doing the smile design by the DSD app, or the initial version of the DSD app. And we see that we have to increase the occlusal vertical dimension and also to do a little bit of crown lengthening, but that will occur anyway by placing the implant. So again, the planning is done by matching the cone beam CT with the STL file of the walks-up and placing it tooth by tooth. We have, in some situations, narrow implants because we have to respect a certain amount of bone and soft tissue around it, as we talked before. Okay. And we plan a guide where you can see that one of the implants is really out of the canine. Very many times you don't have enough bone, so either you place a multi-unit, you plan a multi-unit abutment which is angled, or what we do in this case, we don't load that implant. The rest will be loaded, but you can see that the canine is not loaded, which is completely fine to be covered. Yeah, it's stable, but I didn't want to use any tilted, any angled multi-unit abutments because we have enough implants to load it. In this case, because the teeth are very short, we did also a metal frame of the provisional, which is not always necessary because the patient are not allowed to use the force of the bite for the first 8 weeks of the osseointegration or 10 weeks of the osseointegration. You remember, right? Immediate loading. Okay. So this is the surgery. The same way is another implant system. Generally, I use implant systems which are having self-cutting feature so have very good primary stability. This was also with the external. We can do the grafting and so on. In this case, also, yeah. So this is the situation after the loading with a provisional. You see the one implant is not loaded and the metal frame is to be seen. What you see here, it's a small, I wanted to show you that, is the small whitish points over the implants are not a foreign body, is iodoform, is iode, which is iodine, right? Which is a contrast substance, and this is used when I extract a tooth or postoperatively. Okay, so this is the situation after the restoration. Okay. Another disastrous situation. What is special about this? So this is also one of the patients, like many others, which are really cleaning today, and is very satisfied. This is one of the men who was very, very anxious. So this is always the situation when the people come with that kind of teeth, right? So this is the situation of the 2D picture. I always do a 2D picture as an overview and a 3D picture for the planning, yeah? So in order to have, first I need to know if I can do an implant, or what kind of planning do I do? Do I do my cone beam CT as such, or do I do my cone beam CT with a Lego stone as a matching procedure? That is why I need a 2D before, right? So this is how I approach every patient. And then we go for the 3D cone beam CT and an STL file and we plan the implant this time we need to do pin supported restoration. We do sinus elevation at the same time, I suppose externally, I don't really remember. And in the lower is always, the bone has always a better quality. You see that the softwares are a little bit different of planning, but the principles are the same. We are thankful if we have informations about the bone density in order to see the primer stability and to guess the primer stability. This is a strategy which we need to know when we do the surgery. We cannot definitely load implants which are not primary stable, which you can see here, right? Only those who are primary stable, otherwise it will be not a success. So you can see up in, we could have done also 6 implants in the lower. In this case, the rules are 8 in the upper, 6 in the lower for fixed. So the planning is taking into consideration the anatomical tracing of the nerve, which can be done also inside the cone beam CT, as you saw before the break, right? So the provisional restoration is made, and the specific thing is, in this case, is that because of the substance loss, you see the soft tissue and the bone defect, which we had after the provisional, we did another scan over the provisionals and another registration of the movements. And we implemented then, because in the beginning we didn't have any parameters for that. It was really everything very uncontrolled due to the dental situation. So we did, in this case, scan again. We uploaded it into the module software, which registered the movement, and the movement will be uploaded in the module of exocad, which is the base of the planning for the final restoration. And the final restoration will have a pink component this time. In this case, the technician has to take care that the distances between, that the pin component is made in a way that the patient will clean with the interdental brushing between, although is a screw retained restoration where we can remove regularly, but still it's important to be cleaned by the patient accordingly. Also, we can place it into an articulator in order to check everything by and do a ceramic layering. Sometimes we work monolithic and we paint through ceramic. I will show you the technique later on, a little bit later. Or we really layer with ceramic, and therefore we have to take it out from the digital workflow and place it in an articulator in order to be able to do the ceramic coating in a best occlusal way. And the patient is really very satisfied. Okay, another case. What is specific about this? She is long-term patient, anxious also. She was a study patient, not a study, a course patient. We have a lot of courses in the house where we do all these cases. And she was wearing an insufficient partial denture. Now, we have here a digital walk-up. And the planning of the implant with another software, this was 3Shape again, but the digital data was the same cone beam CT and visualization of the future smile by the scan. The guides will be supported by pins, and the lower jaw, we have 2 guides. Again, one will be placed by the left side, will be placed by the teeth existing, and we place 3 implants. Then we go to the right guide, we place we extract teeth, place the 3 implants, mount the 3 implants, and place the others. So it seems or it sounds complicated, but it's much more secure. Imagine that you mount the guide on these 3 implants in a very perfect ways. If that doesn't match, anything else will not match. So this is the condition for the next step. That is why it is very, very precise, right? So then the provisional was made in advance. Okay, then the surgery. She is quite blue after, after 1-2 days when she's coming to the control, but this is depending on the individualities of the patient, of course. And then after the healing, we'll go to the final. The final, we realized that the provisional was very short. So the smile was not really nice and pleasant and not big enough. I mean, she didn't have the right exposure for the teeth. So that is why we decided to add a pin component and as in the wax-up. But at the end of the day, it was also without or in the upper and with in the lower. So we really have to see how much is missing from the provisional. The provisional is made in advance. Sometimes you need to correct it. So sometimes we have to do that. Now, we do an intraoral scan, as you can see from the final situation, which we match with the cone beam CT and with the base for the evaluation for our aesthetic parameters of planning, which is the topic of our prospective study. And now, yes, now the patient has a right exposure of the final teeth, and she is quite happy. Okay, another guy, which has also a design. I don't know. This patient just find me, right? It's actually, I don't know. You know yourself, if you have a certain focus on a certain issue, on a certain kind of treatment, the mouth-to-mouth propaganda will will bring patients which have similar problems. So at some point, that's why I always say is I have more full arch restorations than single teeth, I have to say. And also the full arch reconstructions are more challenging and more demanding, and of course more satisfactory and more spectacular in the result. So when you, on the other hand, I love to teach on that, because if you can manage the full arch reconstructions, you can definitely manage a couple of teeth. So if you understand the concept, then it's no problem to take care of the couple of implants, right? So also the question is always a treatment plan procedure, and that is why I addressed before the break the rules of 5, 10 to 20. You have to treat and to plan on the long run, and don't do any compromises. This is something that we do maybe at the beginning. You say, oh, maybe it's holding, but if you have some golden rules, some thumb rules, then you will have a long-term success, and the patient will be satisfied at the end of the day. Nothing is so unsatisfactory than the frustration that every 2-3 years, after 2-3 years of restoration, of an expensive restoration, you really have to restore again or to change the construction. Now this guy has also the teeth has to be extracted. Is everything a perio case? So we have also, as you can see in the lateral zone, a vertical bone loss, which is really more than 8 millimeters. So we don't have really had a chance to do something on the long run. That is why, but he doesn't necessarily want a tooth by tooth reconstruction, and is not also the youngest. So we can plan in this case all on 6 or all on 4, which is not my favorite, but depending on the indication. And there are concrete indications about this. I mean, if you have bone in the regions 1, 2, and 3 on the left side, right? Then you can do a normal restoration with internal or external sinus elevation, okay? Those are treatments, surgical treatments, which you really can do with a high predictability. Now, this is the group 2, very conventional. The group 1. Group 2 would be when you have bone only in the region 1 and 2 on the left side. Huh? So that means you can have to use 6 implants, but the distal ones for a fixed restoration has to be tilted. Yeah? And group 3 would be the situation when you have only bone in the frontal area and the patient is not willing, this is also for the group 2, is not willing to do any sinus elevation, or the medical conditions they don't allow, and the patient is not the youngest. So then you can do those kind of restorations, and in the group 3 is the Zegoma implant, which you can do if you have the skills. If you have the skills, right? If not, you advise the patient to a specialist doing that, if that is the wish of the patient and the medical indication. So here we had all on 6 in the upper, all on 4 in the lower. So we did a project, okay, and the situation. We used in the upper jaw again 2 guides because we maintained the lateral teeth and placed the frontal implants. Then we removed the guide, placed the second guide on the frontal, and placed the tilted implants in the lateral. So that was the strategy. And all the strategy is always thought or discussed with a planner in half an hour before the surgery. Actually, one day before we get back with a planner and with an assistant and with a technician, we go through the surgery. Why? Because it's the most, or the origin of many mistakes is, except of the lack of the accuracy, is the lack of communication. And there are things that the technician doesn't know about the clinical situation. And I will give you an example in a minute. And also there are things about the patient and about the surgical and anatomical details which the technician doesn't know. So this has to be discussed, and the assistant is there because everything has to go smooth, and everything during the surgery, everybody has to know at a minute what is happening and what is the next step. Okay, so in the lower, all on 4, we use the 2 canines in order to support the guide. Okay, those are all digitalized data of the STL files and so on. So we have everything made digitally, and we go to the materializing these guides. As I mentioned, in the upper, 2 guides, and in the lower, 1 guide supported by 2 teeth, right? So this is other concept. So it's no case the same, no 2 cases the same, very rare. So you see, you keep the teeth, you place the implants flapless in the, really do a minimal invasive surgery. This is another system which is a sleeve-in-sleeve guided system or implant system. So different implant systems have different guided trays, which we have to take into consideration. But again, I always use implants which are primary stable in order to do immediate loading. So this is on mountings of the frontal implants. You can see the lateral teeth here, and then we remove those and we place the rest of the implants, as well as in the lower jaw we go accordingly. You can see again the position. This is also a case of this from the study, is again the position of the implants very away from the buccal is something that in the planning is needed to be set, and this is what we discuss with the technician, and he has to know, but we have to reinforce. And this is the provisional made in advance. You can see is not even a pin component there, is not necessary. Why is it no pin component? Well, mostly you have to think about, and also this is a thing that you have to talk with the patient in advance, because patient will be very surprised if he doesn't know that she had a pin component and then suddenly he has. Well, if you have still teeth in the mouth, which have a certain and a proper visibility, the range is the probability is very high that you don't need pin component. But I will show you in a minute the classification where you can still know, how do you know when you put pin and when you don't, okay? So just the parameters. I like to have parameters and principles and coordinates. So this is the final, by the way. Yeah, so exactly, this is exactly what I wanted to say. So this is the aesthetic planning. That means, look at the first category. First category is in the left, right? In the left part is, you can see crown height space between 8 and 12. Those are when the crown height space, which is the distance between the bone and the incisor line, is 8 to 12, you can have the high probability to make an immediate placement, immediate loading without pin component, because this is the physiologic dimension of a teeth, of a tooth, or of the teeth. Now, category 2, in the middle, you can see CHS, like crown height space between 12 and 15. What is that? You see, you have a little bone loss. So those are the situations when you have perio cases, when the teeth, the natural teeth, are already elongated and you have bone loss. So you can still do immediate placement, immediate loading, and fixed prosthesis, FP, number 2. But you might consider a small pin component of 2-3 millimeters in order to support the lip. Otherwise, the lip will be not supported and the patient will be unsatisfied. Those are also aesthetic parameters. And last but not least, FP3, when the patient has a lot of bone loss, horizontally as vertically. And that means there is the patient comes edentulous or partially edentulous, but edentulous mostly. Then we just make a construction supported by implants. There are still situations when the patient doesn't want denture, they want really a fixed constructions, and then the crown height space is bigger than 15, so we need a big pink component. So you can do, in this case, screw retained, or you can go removable also. Well, women always want fixed, men always want removable. This is just a personal statistic. So, for example, this guy, this is also a course case. He came 2 days before the course, so it was a course patient suddenly. So we had to act very fast. So those are the insufficient initial dentures. What do we do with them? We do some opaque points with gutta-perca in those old dentures, so it's no way of now of walks up and so on, and new dentures, which will be the real approach. But we do those opaque points as for the calibration, for the matching of the STL with the cone beam CT. So we place these dentures prepared accordingly into the cone beam CT, and this is the base for the matching of the two components. Now the smile design will be done in exocad by the software of the smile design of the exocad, yeah? So which is also a possibility. So we do it many times. So this case is a pure digital case, yeah, pure. So we didn't go out of nothing, we didn't print anything, and so on. So, yeah, so we then planned the case accordingly. We did a 3D walks up in exocad, yeah, and then we matched the initial scan of the patient with the scan of the denture and with the walks up of the denture, and based on that we'll do the guides for the surgery, yeah, in the upper and in the lower. We have very thin bony situation, but still it was possible. We'll see in a minute. Yeah, we extract the tooth and place those implants. We need pins additionally because it's an edentulous situation in the upper jaw. So, and you can see the situation. I can see in the room that it's cold out there. Is it cold? Yeah, I can see it's cold. So, and also we plan the guide, yeah, or the technician is planning the guide. And then we print everything out, the model, the guide, the sleeves, pins, and this is the provisional. You can see you compensate, but again, here is a mistake because the patient had dentures, so we need a bigger pin component. Nevertheless, the provisional was not so big. This is something, a learning curve which the technician had to learn in the meantime, and the communication had to be appropriate between us and the technician to say, okay, pin component, yes or no. So actually, we really, it's a cooperation as never before. Otherwise, it's an origin of mistakes, yeah? Because he doesn't see, he sees the patient, but he doesn't, when you look virtually in the software, and the planning software, it's not the same as the reality. And this will confirm, can be confirmed by any technician that you work with. Sometimes the things that you plan virtually, the teeth that you model virtually, when you mill them, when you print them, they have a different, I mean, have not the aspect that you imagine. It is connected with the aesthetic feeling of that IT freak, which has to be an anesthetician too, and also experience. Experience is what is also leveling the learning curve the more it goes. So this is after the surgery, immediately it was successful. So really it's fun to do digital dentistry with all these new technologies because it has a fast result, and it is really like a virus. It's like when you go to Apple, you don't go back to Windows anymore because it's just more appealing, it's faster. You have from the beginning on a provisional, like the way you want it, and you don't do any improvisations. You can see here we implemented the pin component in the final because sometimes it's not enough. So the provisional is and not always perfect. Sometimes yes, sometimes not. So either its teeth are too long or it's missing a pin component. So that is really depending on the case. We implemented accordingly the pin component, and then the patient was, he doesn't like really to smile, but yeah, he's satisfied, if you believe it or not. Now another case is different. So this guy comes with a denture which doesn't look very bad. The occlusal vertical I mentioned is okay, but the teeth are too small for this big guy. It doesn't fit. This is a French actor. So he comes like this. So definitely he needs fixed teeth because he's in the middle of his social life. And this implant in the lower, we didn't do it, so we don't do things like that. But it's, it's not a statistic, but it's functioning, so we leave it. But in the upper jaw, we need to re-establish the smile with the golden proportions, and we did it at that time with with a handmade wax-up. Yeah, why? Because we go standard-wise now. We do an wax-up of the future teeth, future denture, future teeth, and this walks up this is the way to go, not like in the course patient, and we do the gutta-percha points accordingly, right, for matching. This is the radiologic guide. Yeah, this is actually how we mostly go on in the full arch reconstructions, okay, in the edentulous cases, in the edentulous cases. So we scan everything. The scanning is the preferred activity of my assistants because they know now how to do it. They are faster than myself. They know about the criteria. So what I advise you is to teach your assistants to scan and to show them one of the videos that I showed you before the break, to have the rules done, so they don't miss any soft tissue, they don't miss any tooth, they have the right angle, they use the right technique, they know how to go along with the arrows, they know how to cut out things and place the other things. But it's a very nice IT tool which the young people love, and they are faster than ourselves, the old seniors, right? So now this case was also planned with 8 implants and internal sinus elevation. Guide was planned, this time with SMOP, as you can see, which is connected with the CS9600, and an internal sinus elevation, right? So in this case, we did a frame, and we milled in wax the frame of the provisional. And this is the frame, and then it will be a metal frame with a PMMA coating as a provisional. We printed guide And this is the situation which we get sometimes, not always, but sometimes we get the screw retained abutments. And this is the guide for the lower jaw. In the lower jaw, since we didn't do immediate loading, I needed only a simple guide. This is something that you can use just for the position of the implants without any pretension of loading or of a fully guided, as you call it, fully guided surgery, right? So this is placed on the prepared teeth in the lower. This is the provisional in the upper, and the screw retained restoration or screw retained abutments. Of course, we close the gaps with the grafting. We use in this case we used an internal sinus elevation by the hydraulic technique, and the provisional will be placed on the screw retained abutments and solidarized by, as in any case, I didn't show it until now, with an self-curing resin. Self-curing resin, the holes by the screw retained abutments will be closed by Teflon, and then it will be closed, right? So like this. So the patient looks like this, like in the picture, like in the radiography. And 2 days later is a very unspectacular healing, and the patient has almost no pain. So the flapless surgery has a huge advantage just 1 second. Okay. I'm sorry, I thought it was an urgency, but it's not. So I have, so this situation after the provisional, and we have a situation after the final with the soft tissue accordingly, and we did at that time an impression over the multi-unit abutments with an open tray. So if you don't do a scan in a full arch with a continuous scan technique, as I showed you before the break, you do an external, real impression over the multi-unit abutments with an open tray, okay? So in the lower, we did it with a closed tray since we did single teeth, so it's not a big danger. And this is the situation of the modal and of the prosthetic situation, which we get afterwards. Now, zirconia frame with a big layer ceramic. Now we do that today a little bit different, but this is also a way to go. The zirconia, nevertheless, is, as you know, a very rigid material, but it doesn't have any elasticity. So that is why the precision of the prosthetic manufacturing and also of the impression is mandatory, because any fit which is not passive enough will give breakage in the zirconia. And ask me about learning curve, and ask your technician about learning curve. So what we know is that we need a passive fit, especially that's why we do over the multi-unit abutment and not over the implants, especially in conical connections. We use a continuous scanning technique or an open tray, so we don't risk anything. At the end of the day, the result is important, and not to be fully digital if it's not feasible, yeah? So, and we take zirconia with a high rigidity, 1200, 1400 megapascal, right? So, and we layer it with the ceramic, yeah? It will be a full arch screw retain in the upper and single tooth in the lower, yeah? So, this is the situation afterwards, and you can see the situation is purely supported by the multi-unit abutments, is really a great construction, and the patient is really satisfied. He's coming still to us to recall, as we said and as we told him, and is really satisfied. Another guy, which is a German singer, he came with a denture he was gluing it with glue. with common glue. So it was, because he had no time, and he took his time when he became 80 to do a fixed construction. So let's go fast through the workflow. I don't want to keep your time very much, but we will cover it in appropriate time. So again, you see it's repeatingly, the main workflow is repeated. We do a walk-up with a gutta-percha points. This is the radiologic guide, and with this we do a cone beam CT, which is the base for and we scan it. So the scan with the cone beam CT will be matched, and that is the base for the planning. We placed also implants because he wanted a really high-end construction. It was placed by pins. So when you have 3 pins, what you need to do and to take care of is to place the implants which are far away from the pins first. Then remove the pins and place the implants which are near the pin. Why? Because you always have to take into consideration the probability of a mistake or of a mismatching, where if we drill and we drill into a pin is, well, this didn't happen before, but as a precaution tool or even as a prophylaxis, we act accordingly. So this is the provisional in advance. We go to the surgery, and the surgery is really unspectacular. After 2.5 hours, he has in full anesthesia, he has his wished construction, and those are the implants after with the multi-unit abutments, and this is the patient immediately in the recovery room. Yeah, so he was fit, really fit. He wanted to participate to Eurovision, but he didn't. But he was actually fit after 2 days. So this is the right picture is the picture with the provisional. In the left was with the old denture. So yeah. So he said, "I'm like newborn. I am like newborn." So the final result, the final reconstructions was done by Mio technique. This is a technique which is using a zirconia, a hard zirconia, which doesn't have to be layered by ceramic. And that is why it's not has to be reduced, which is a win, because zirconia will be breakable when the connectors are too small, or when it has to be reduced in a way that the ceramic gives you the aesthetics. So Mio is a painting technique of the zirconia, which is a painting ceramic. So this is something that I would recommend you. One of our technicians is specialized on that. So the results are really amazing, and the zirconia has not to be reduced. So it's a massive zirconia, so that it's an added value to the frame, or added resistance and stability to the frame, right? So this is actually a case which I did this week, and it just posted the big pictures, I loaded up the pictures. Is a lady who is an anxious and a patient which has some problems, this kind of problems, and also an anxiety, so anxious patient. So this is how she comes. And since she's coming from a very, not a local patient, we needed to do that in the same session. So no dentures before, no walks up before, not try-in before. So we did it that way. We made in Exocad a smile design. By eliminating, she has a gummy smile, but we eliminated the gums, right? We eliminated the gums. That is why my technician placed the gums, but afterwards for the provisional, he eliminated them, because we don't need it. The patient has teeth and has a gummy smile. So we planned the case. She had bone for 6 implants in the upper, 6 in the lower for fixed constructions. So in this case, we did also an tooth-supported guide. So in the upper jaw, 2 guides, in the lower jaw, 1 guide. In the upper jaw, we extracted all the teeth and maintained, not forever, just for the first guide, the 2 molars, and I placed the 3 implants in the front. For the same reasons, I don't want to repeat myself. It is much more precise. Now, the challenge of this situation was, and maybe you see it in the planning on the right side, that the soft tissue was 1 centimeter thick. So the problem of the situation is that the distance between the color of the implant and the sleeve is limited. Totally, it has like 6 millimeters. So we don't have place to place the guide only if we open the flap, which is also fine because the situation is catastrophic anyway. So I need to open the flap, I need to clean, I need to rinse with antibiotics and so on. So I remove all these frontal teeth, leave the molars, place and open the flap. Now, the technician had to do the guides in a way that he predicts how is the height of the situation and how much can I open the flap. And this is also a question of communication between clinician and technician, because he doesn't know how much you can open the flap. Palatally, you cannot even open very much. So that is why the communication is really necessary, just to re-emphasize. Nevertheless, it went very well. We made the guide accordingly. You see, as much as in the right picture is cut, as much I needed to open the flap and go for the bone, okay? So, and then the second guide was placing the implant where I extracted the molars, mounted in the frontal and placed in the lateral. And you can see that at some situations we have really a very little bone left when you extract the molars. Nevertheless, since she's here and she doesn't take very many surgeries, we went for this challenging situation. Very important as the implants are primary stable. You can see that how important it is, the accuracy of the comb density in that case, and the accuracy of the STL file and the matching accuracy in order to have an exact planning, right? So lower jaw with consideration to the nerve, the 6 implants placed, and those are the guides, right? The upper two pieces, you can see that my technician prefers to do compact guides and even solidarization of the right to the left side instead of the frame in order to have a stable situation. And this is very, very important in order to have a stable and situation. This is the digital aspect of the guides, the both of them, and also the dimension of the sleeves, upper, lower. You can see that in the lower we did 1 guide, but we supported it additionally to on the last teeth, and we placed the pin in the middle. You can see the pin in the middle of the guide in the frontal area, right? So this is the provisional made in advance. This is another solution to adapt or to fix the upper provisional in the perfect occlusal position by just simply doing a template which is solidarizing or it's matching it on the palate, okay? So I don't have the pictures or the video of the surgery because we didn't have time for that since the case is from this week. But all the cases are so interesting and so, exciting that I needed to share this with you. So you can see 6 implants with the upper and 6 implants in the lower in this perfect planned position 4 millimeters below. Now we have, of course, more than 4 because we have a soft tissue which is extremely high. It's very unusual. And this is the pictures. Those are the pictures which we did actually yesterday by the provisional. So it's really, the patient is really more than happy. And this is 3 days after the surgery. I mean, you see that every surgery is depending very much on the individualities of the patient, not only at anatomic ones, but also the ones considering the healing. And that is why I emphasize, and I want to warn you also by the medical condition of the patients, which can be spectacular or not known by the patient. So this is something that you have to check very properly and talk with the anesthesiologist to check and so on. But also by the healing. Some people have a real swelling after one implant, and after full arch reconstructions have other people no problems. Generally, we tend to reduce to minimize the surgery, to shorten the surgery, and to make it as predictable as possible and in the first run, right? So now I promised you before the break that I show you some other guides method. We are going slowly to the end, so just just a little bit patience more. We don't have much more anymore. So this is the sleeveless guided surgery. So when I said that there are sleeve guided surgery, this is a sleeveless. So you don't have those sleeves in the guide. The movement is guided by the handpiece. As you can see, the handpiece has two small devices which are running through some tubes which are guiding the movement. Looks complicated, is absolutely not complicated. It is has a lot of advantages, and I will mention a couple of them. First, because the planning is done by Lego stone and the matching, since the artificial intelligence and segmentation is not so far yet, we do the matching for SMOB by Lego stone, and we have less deviations by that. This is number one. Number two, we have space to see the surgical side. We have space to see what we are doing and to do additionally soft tissue surgery or to handle by visibility. You have a good irrigation, and last but not least, and the most important thing, you don't need any guided tray of the system. You use the normal implant placement system or the tray of the implant system, respectively implant system. So it's compatible with the normal tray. You don't need a guided tray. It uses the normal drills. That is why it's important and can be used with any implant system without buying a new tray. So the guide looks like this in a clinical aspect. So a couple of pictures about full arches and not full arches. So it can be done in many situations. What you have additionally, except the resin printed guides, is a couple of stops which you need for certain drills, yeah, which you see in the right side upper. And this is the aspect of the normal handpiece with this applicator and the stop, and you get a protocol which is guiding you through all the sequences of the placement. So, for example, this is a lady with a removable denture. The denture will be placed. We plan it for a fixed construction. The 4mm rules is respected. We go to the surgery, and we have a very nice soft tissue situation afterwards, which we need also to protect our implants. And this is the final restoration made in a CAD/CAM procedure. And this is the happy patient, right? Okay. Another lady, she is 30 and she didn't wear any denture because she couldn't. So therefore, we have to plan a fixed construction with an immediate loading. Look at the situation before of the bone on a cone beam CT. You can really evaluate very clearly the structures, and we do on a cone beam CT in this case with the Lego stone. You can see the Lego stone on the left side, right? That is giving us the best matching, actually. So in this phase, the planning will be done and the provisional in advance, yeah? So we place the implant in a flapless procedure, and we do a provisional, and then we go for the final restoration. We also do a scan of the final restoration, which will be matched with the planning subject for our study. But the patient is really very, very happy with her teeth. Another disastrous situation, I don't know who did this kind of denture, but for sure it looks like it's from another patient, right? So nevertheless, also pin guided, the patient is edentulous, same system. So it's a big advantage that the cone beam CT is connected with a SMOP, so we can transfer the data from here to there and open the planning system in the software of the Carestream. And we place the implants accordingly, and this is the final. So yeah, it is a life-changing dentistry, as you can see. Another system is a dynamic navigation. So you will remember at the beginning of the lecture, freehand, static, dynamic. Dynamic navigation has no guide. It has advantages and disadvantages. The advantage is, well, the steps are also scan plan, but you don't have to manufacture a guide, and done. The scanning means the acquiring of the digital data as well as always. This system is using a planning, the same as in the static surgery, and the surgery will be done live by following a target. You can see the planning is similar, is by matching the WhatsApp with the cone beam CT, right? And yeah. And with using a reference, which can be on the head or a reference on the neighborhood tooth, we are tracing the neighborhood teeth, and this will be the calibration of your handpiece with the camera. Yeah, based on this calibration, we'll have a target which we have to follow, right? Which we have to follow, and when we are in the middle of the target, then we are at the in the target of our placement. You can see, I forgot to stop the volume, but nevertheless, yeah. So this is a full arch situation made in the same manner with dynamic navigation. In this situation, we use the mini implant as a reference, yeah. So the advantage is that you can do very freely all the additional grafting procedures and place the implants accordingly, also with a sinus elevation. This is the final restoration of the same patient, and this is the aspect of the smile. What do we know about dynamic navigation? We know that it's more precise than the freehand navigation. Nevertheless, is not as precise as the static one. We know that we have 4 systems out there of dynamic navigation with advantages and disadvantages. Nevertheless, generally, when there is a study which shows that if groups are starting with dynamic navigation and other groups work with static and then goes to dynamic, the ones which started with dynamic have much better results. So it's always the tool which you learn first. There is a learning curve, right? But it has the advantage that you're decreasing chair side, and you don't have the costs for the guide and decrease human error. So it's a freehand surgery which is controlled, which is guided still. Yeah, it's a freehand surgery which is still guided. Now, as a resume of all what we said until now, following accurate and true and precise technologies, placing them in a predictable workflow, and respecting some parameters, we can get to very high aesthetic, stability, and functional results. To evaluate these cases, which are the subject of our prospective study, we evaluate this by matching a final scan with a cone beam CT of the result of the placed implants to see if the parameters which were respected led to an stable aesthetic result. Now, the success rate of all these cases totally is really high, higher than in freehand, I have to say. But the aesthetic prognosis depends on parameters which we still need to confirm by finalizing the study. So we can say that accuracy, trueness, and precision of devices still need, of all the devices, still need more studies and consensuses. That the accuracy of matching has to be also studied and documented and validated. That we have that algorithm of insertion depth and of the bone soft tissue thickness of number 4, which has to be confirmed. We have to find, to define, to describe, and to systematize minimally invasive surgical techniques additionally to the digital dentistry, which is not the same with the first dentistry with a big flap, which we did years and years. Then the S-shape emergence profile has to be anatomically did, and here we can rely more and more on the technology by finding Z, by finding the level of the abutment, by finding the right shape of the emergence profile. The 3 to 4 millimeter interabutment distance is a given. It has to be respected and has to be implemented by artificial intelligence in the planning softwares, and this is what we are working on. And we have to have a maintenance philosophy. However you construct it for yourself, or you respect what you follow what I advise to you, concerning occlusion, concerning decontamination, concerning prophylaxis of peri-implantitis, this is a part of it. This is a part of it. So those are preliminary aesthetic parameters which we can mention. And of course, we hope and we work also with the Digital Society and with a group of colleagues in the implementation of these parameters in the planning softwares. I have to say, and actually is documented in the literature, that the accuracy is depending on the surgeon's experience. That is why education has a main role in shortening and leveling the learning curve in order for you to do less mistakes, in order to gain good experiences and not to do the, to eliminate failures. So we have, by our questions, do we have disadvantages which we supposed at the beginning of the lecture? You can see, yes, we have those advantages. It's faster, is more precise, is minimally invasive, is giving a nice provisional immediately, is a really life-changing dentistry, is a fast result. But we still need studies, we still need validation. We still need to level the learning curve and to create predictable workflows, predictable technologies, accurate, precise, true technologies, which are implemented in a coherent and predictable workflow. And more than ever, it's an interdisciplinary approach. So the training and education of everybody is needed, not only for the clinicians, but also for the technicians, which need all to speak the same language. Because you ask of artificial intelligence, yes, it is the tool behind a lot of technologies, and it is inside, even if you don't know. And it has advantages in the implementation by accuracy, by standardization of the procedure. Think about the Frankfurt line of the anatomical markers. Saves time and is predictable, right? But it is challenging because it's complex, it's expensive, and so on. Nevertheless, it's implemented in all technologies, also in the printing. Now, another technology which will come, or it's on the road, actually it's already there, is printing of zirconia, which can be done for crowns between 25 and 100 microns, and there's more studies for that to come. What else is coming is 4D printing. That means the 4D, for the fourth dimension, is time. So there is printing of materials which are able to change the dimension in time. And last but not least, I would like to show you the future is now. So this is what technology, which is also based on artificial intelligence, like augmented and virtual reality. And this is the reality. And this is how I see that the education will go on as a natural following of the online education. And this is also only on the question of circumstances and also of demand of the people, maybe also dictated by the circumstances. So inhale the future, exhale the past. Thank you so much for your attention, for the kind invitation. Thank you for all the high-end technologies which we have opportunity to use, and I had the opportunity to talk about. Thank you so much to Taiwan.